Seems good.
Hmm.
Okay, I am ready whenever.
Excellent. Thanks so much, Isabel. Welcome, everyone, to the Universal Health Plan Governance Board Transition Committee. Thank you for your time this afternoon. As a matter of tech check, Isabel, will you call a roll call?
Yes, I would be happy to. Judy Richardson,
I'm here.
Mike Leahy,
Here.
Mary Lou Henrich.
I'm here, but I can't turn on my camera, Isabel.
Okay, well, I'll
Thank you.
work with you. Charlie Swanson is unavailable today. Richard Gibson,
Here.
Antonio German,
Here.
Eve Gray,
Here.
Anne Lovejoy,
Here.
Jamie Osborne,
Here.
Mickey Durding,
Here.
Paula Weldon, Paula, I need to give you permission. You should be able to unmute now, Paula.
Here.
Sorry about that. Thank you. And Jensina Hawkins, I didn't see Jensina. I believe she's feeling under the weather. And that's everyone.
Great. Thank you, everyone, again for your time. Go ahead and advance the slide. Take a look at the agenda this afternoon. We'll have board updates from Dr. McDonald. Thank you very much. We'll launch into a discussion of governance and statutory gaps. We've had this topic before, so it shouldn't be new. Talk a little bit about the financial transition and perhaps get to engagement. Then we will have some brief member reflections and any homework going forward, as well as public comment. Do we have pre-scheduled public comment today, Isabel?
We have 2 people signed up for public comment today.
Excellent. We'll make sure to have room for them. Director McDonald, take it away.
All right. Thank you and welcome, everyone. Thanks for being here. I'm Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. I'm going to very briefly provide some updates from the last board meeting because, as per usual, we have a lot to get through at this committee meeting. At the last board meeting, which was just a week ago, there was a great presentation from Dr. Chow about overall potential for administrative savings under a universal health plan. And then we had a very detailed discussion, a lot of which you all have been present for, and came to a consensus around the potential for administrative savings, which was a very exciting moment for me. The other things that happened, the board had a discussion on a couple of elements of the revenue proposal, and I'm actually going to just share with you now a couple of the highlights. So one of which is there had been something that had been in the revenue proposal, called the household size rate readjustment that was placed in there to sort of have higher income families who had more members in their households would contribute more to the universal health plan than higher income families with fewer people but at the same income. After a lot of discussion, there are lots of pros and cons about that. The board voted to actually remove that from the revenue proposal. So that's no longer part of the revenue proposal. The other portion that I think is important for this committee to know is that again, there had been in the proposal a Medicare Part B premium tax credit of 100% to offset people who were having to pay Part B premiums. They would get a tax credit on their Oregon state return. However, again, after a long discussion and lots of pros and cons and really great information provided, what the board has decided to do is instead of that mechanism by giving people 100% tax credit, a universal health plan will actually cover the cost of all Medicare Part B premiums for all of those who are in the state and who would be required to be eligible for Part B premiums to pay those. And that includes those ones that are called IRMAs, which are when people have higher level incomes, they have additional amount that they have to pay. So the upside of that is everyone is covered. That revenue that comes back from the federal government is guaranteed. The downside to that is it does increase the total cost of the revenue plan and what will be required to make up in sort of the revenue replacement target. So big discussion. There's been a lot going on about that, but those are some important things. Because of that, we did not get to sequencing at the board level, sequencing the transition plan. So that is coming up at our next board meeting. And then my next slide, I think I've shared with this committee, but there are two board member positions that are open. One will start in October of 2026, and the next one will start in January of 2027. We are asking for applications. Now, these positions are for people with experience in engagement. So that is one thing that's important to know about them. There's a link here about the boards and commission website, which is how to make an application. If you have already done an application, you can check and see if it's still up to date. I think it's like a 2-year time frame. Isabel's nodding. So you have 2 years from when you first submitted it. It will still be up to date and viable. And we're going to go through all of it and see if anyone's interested. If you aren't, if you know that you did one previously, shoot us an email too. That will help. But the deadline is right around the corner, June 22nd. We need those applications received. There's going to be a board work group, small work group of people who are reviewing them along with staff. And then a decision will be made, and that list will be sent to the governor's office, because the governor's office ultimately makes a decision about who the board members are, and then eventually they are approved by the Senate. So that is what I have. I'll see if there's any questions or any comments from our board members who are at the meeting, if they want to add anything.
This is Mary Lou. I don't know that I would exactly say that we had consensus, Mimi, on the administrative savings. We each gave our best shot at what we thought the number might be. And then I suppose, Helen did say, at least to the side to me, that, and maybe to the whole group, that averaged out to be 11.25. But
I think you're accurate. Thank you, Mary Lou. That is
so
true.
anyway,
People had different ideas. Thank you.
Right. And we actually had, a couple of, actually our co-chairs of this committee had, very divergent conclusions. So anyway, I just wanted to say that, yes, I think we all expressed our stuff. I think that you got a number, it came out with an average, but I just don't know that I would say that we really had complete consensus yet.
Thank you. I agree. Thank you for stating that more accurately. I appreciate that.
Thanks.
All right, I think that will do it for me, and I will turn it over to Senior Policy Advisor Lee Hastings.
Great, thank you. So we'll be discussing a couple different topics, starting with statutory gaps, which is one that we've talked about before. And just something that I want to kind of set up as a framing for these conversations, just to note that what we're really looking for from this committee is a direction. We're not expecting some sort of final written in stone absolute thing. We're in a phase right now where the information that we're getting is going to help inform some of the analysis that we'll be doing in the future. So we're really looking for, what direction do we need to be pointing towards? So with that, let's dive in. All right, so there are two main things we're going to discuss here. I think the first will be pretty easy. The second one may be a little trickier, board composition and appointment. And then secondly, we'll discuss coordination with other coverage, with that focus really being on how employer-sponsored insurance will interact with a universal health plan. Next slide, please. All right, so hopefully this one is pretty easy. I thought we had a great discussion last time. We presented a couple different ideas for what the board composition and appointment process could look like for what would be a new board that would oversee a universal health plan. And this is kind of the proposal that we're putting in front of you here today, and would just like to know, does this feel correct? So you can see in the little box on the side some of the changes from what was presented before. Per your feedback, an increase in the number of board members from 9 to 11, and then also clarifying that while this is a new board, that there should be some number of members to be determined that would effectively roll over from the existing UHPGB in order to create a little bit of continuity between the boards. Oh yeah, and then I think on the side it says at least 4. So that number to be determined, but at least 4 of the 11 members to start. Similar to our existing board, they would serve staggered 4-year terms, be governor appointed, Senate confirmed, and have specific seats reserved for some of that really subject matter expertise that is necessary for running effectively a health plan that is going to oversee most of the state of Oregon. So a health economist or actuarial experience, someone with provider and delivery system experience, an employer representative, and a consumer representative. So this is the sum total of what we have on this topic. So I'll pause and see if there are any questions, or chairs, if you have anything you'd like to. All right, Eve, I think I saw your hand first, so.
I like this overall. I like 11 as the number. What I would recommend is that we have 2 people from a provider or delivery system. I would recommend 1 inpatient and 1 outpatient. I would recommend 2 employer representatives, 1 from large business, 1 from small. And would recommend 2 consumers, because I think if you just have 1, you can get kind of the token effect going, and it's helpful to have multiple consumer voices.
Thank you so much for that. And these do represent minimums, but I very much appreciate you expanding on what that could look like. Richard.
When does this board start?
This would be pending some sort of state legislation. Effectively, this would be what stands up when there is an official legislative mandate for implementing a universal health plan.
You mean it might be as soon as the legislation in early 2027, presumably to start July 1st, 2027, something like that? That would be the earliest? Or is it much later than that?
That would be the earliest. I think realistically, it would probably be later than that, but
Okay.
potentially. All right, Mike.
Thanks. I certainly can see all kinds of discussions for this stuff, but prior to setting the number, to me, I think a more fundamental question is this going to be a working board, or is this going to be a board like we're currently on, where people struggle to meet a couple of times a month?
I think one thing that I didn't include here, but I probably should have because it was raised in the conversation last time, was that these would be ideally paid board members. So hopefully with that, there would be some capacity for people to be able to make time a little more easily as compared to our current board, where all of you very generously are volunteering and donating your time.
Okay, and just one follow-up. So there are boards we've looked at, like SAFE, for instance, that are working boards, but that have 5 members. And here we're going in a direction of more people. Basically, what's the case for more as opposed to a more focused board with a different kind of structure?
Well, from my research, I can tell you that the tendency is that very technical boards tend to be smaller, really focused on subject matter expertise. Boards that have more of an engagement and really wanting to make sure that there's community involvement tend to be a bit larger. 9 to 11 is kind of that sweet spot that's sort of right in between having technical expertise and still allowing for kind of representation of different community groups. That was the logic with that as sort of our starting point, at least. So, all right, Mary Lou.
Yeah, my question, I really think there should be somebody, I didn't disagree with Eve at all with her numbers. But something, and I don't know whether the health economist actuarial covers really somebody who's really good with finance. So maybe that could be included in there or another position. I don't know. I think that that's a real critical person to have on a board like this. And I also think down on the consumer representative, I agree more than one. I would probably, because there's such, there's actually kind of three big groups of consumers as I see it. There's Medicare consumers, there's Medicaid consumers, and there are people who've been in either purchasing their own or employer sponsored kind of commercial type insurance. So I'm not sure, whether we need three or whether, but I do think that Medicare is an important one because it is, large group as well as the Medicaid. I'm not giving a specific recommendation. I just kind of wanted to raise those issues.
Yep, I appreciate it. Thanks for the feedback. Mickey.
Hi there. I would also recommend considering individuals who bring diverse perspectives, lived experience, and cultural competence so that it reflects the communities we serve, and they're better positioned to understand member needs, address health disparities, and support equitable access. And there are some times where, for example, I'm on the Oregon Commission of Asian and Pacific Islander Affairs, and our sister commissions, you have the Hispanic Affairs, the Black Affairs, and for Women Affairs. So sometimes the governor will have like a council and they'll have seats for us. So that could be a consideration as well.
Thank you. Mimi.
I'm sorry, I don't usually jump in on this, but I would just like to put forth for consideration that there be a tribal member representative on this board.
Mhm.
Okay. And Mickey.
Oh, sorry, I was trying to send a heart to the tribal seat. Raise my
Okay.
hands.
All right, then. We'll go to Tony.
Yeah, just to echo some of the sentiments, I really think in order to make this a board that people can contribute from an equity standpoint, is that it be paid positions. I think that's really important for that, just to elevate that. I think the size of this board is an important characteristic of that, and I would argue not to make it too large. There are a lot of stakeholders, and sitting on the policy board the last 3 years, we go through a lot of community representative in bringing people on and trying to meet the needs of everybody is really difficult. So I just caution us not to feel it too large, that we want it to be a functioning board. I would also just direct that the OHA staff does a really excellent job of looking at geography, looking at diversity, and attention to that. I think is really, really important, which Mickey raises up. I really appreciate Eve's comments, looking at the different health delivery sectors. I think both an inpatient, outpatient is really important. I think the employer commentary regarding large and small is also really important.
Excellent. Thank you so much. These are all great comments. Okay, not seeing any more hands. I think we will move ahead then. All right, so our next topic in this section is discussing coordination with other coverage. And again, this is really in regards to that employer-sponsored health insurance, because there is, of course, a rather large segment of employer-sponsored health insurance, namely ERISA plans, which the state cannot compel them to necessarily be part of a universal health plan, but we do have some potential strategies, and we're, again, really just looking for direction from this committee as to what we could explore in the future, hopefully going out and being able to conduct some actual analysis with employers as to their, you know, intentions and likelihood of transitioning. Next slide, please. So this is what we saw last time, but just as a reminder, we have two options, which is where a UHP would be the primary insurance covered, meaning that if you go into your doctor's office, that's what they're going to bill first, and employer-sponsored coverage would effectively become supplemental. Option 2 is that UHP would be secondary. Now, of course, there are pros and cons to both. Option A gets us closer to some of that administrative simplicity. It also does encourage employers to fully transition to a universal health plan because it becomes really not cost effective for them to be offering those plans. It's essentially a little bit of a workaround to ERISA. However, on the risk side, yes, there's a possibility that there could be an ERISA challenge raised. And frankly, there's just not a lot of litigation around ERISA. There's not a lot of case law. So we don't know how that could turn out. So that's a possibility. The other option that would not risk any kind of litigation from large employers would be that secondary, but that does, of course, maintain some of that fragmentation that we currently see in the system. And there's a little bit less opportunity for a universal health plan to become a big driver in the state in terms of having those lives. Next slide, please. So to think about, oh, I'll pause there. Mary Lou.
My question, if we go back to the other slide.
Sure.
If we went with UHP as primary,
Mhm.
then wouldn't that drastically lower the cost of the employer plans should they continue to have them? And so it maybe would, I'm not sure if that would be an incentive or disincentive. I don't know, but it just, am I correct thinking that?
It's a complicated question. It depends who their employer is, because we do have multi-state employers, and if you're using a national carrier, that impact on price is probably less. If you're using a local, a regional, or Oregon-based one, yeah.
Okay, thank you.
That's a great question. Mike.
Maybe it's obvious to everyone, but there's to me, the elephant in the room on all of this is the tax rates and the amount of money, and it clearly we'll clearly have to have a higher rate for either the employers or the employees if we choose primary. But that doesn't appear to be on the pro-con stuff. So I would just add that dimension, is to kind of carefully think this through systematically and not just have a pro and con list.
Yes, it's a great point, and we'll touch a little bit on some of the financial aspects in the next presentation. So thank you for queuing that up for me. Next slide. All right, so of course there are a lot of unknowns, and again, as I mentioned, this is something that we have flagged as an area where, you know, our future analytic work is going to try to get out and do more analysis related to employer behavior. But when we look at different types of employers, there are certain kind of patterns that we can predict. For instance, small and local employers, their likelihood of voluntarily replacing their employer-sponsored insurance with a universal health plan, extremely high. If all their employees are already in Oregon, that's just, it's a really simple kind of maneuver, and they have very limited incentive to be paying for a plan when they're already being taxed to have coverage under a state-based plan. The same is true for those large but Oregon-based employers. So think of university systems, for instance. You know, if Oregon State is a large employer, however, they are based solely in Oregon. Therefore, their likelihood of moving voluntarily to a universal health plan is pretty high because they don't have to deal with any of the complications of out-of-state folks. Now, it gets a little more complicated as we start to look at multi-state employers, and then of course there's self-funded ERISA plans. So we tend to have more uncertainty around those particular groups of employers. Next slide, please. Now, some considerations. We know that nationally, about 2/3 of workers are in self-funded plans, and about 80% of those that work in large firms are in self-funded arrangements. Large employers do account for a disproportionate share of covered lives simply because they are large and they do employ a lot of people. And we know that that self-funded status is correlated to that multi-state. And these are the populations where we do have the most uncertainty. Jamie.
Is there any information that is state specific? I'm not really sure I want to base our decisions on national information. Oregon is, you know, keeping it weird. Sometimes we're a little different than the national averages, and I'd love to see state information on this.
Yeah, it is tricky to find information on how many employers are in ERISA plans, precisely because they don't have to report anything to the state. We have no official data on that, but I can definitely do a little more digging, see if I can get some more precise numbers related to Oregon. Mary Lou.
When I was with another organization and we were trying to change the foods that and beverages that were sold in schools, and we hired a young lawyer who I simply said to her, just call the 198 school districts and say that you are interested in, do they have a pouring rights contract? And if they do, would they please fax it to us? In those days, we did fax. And so by golly, they did. And we found out, you know, it was the bigger schools, et cetera. But I'm wondering whether there is something that could be done simply by who are the large employers and giving them a call and asking, you know, how do you do it right now? And, you know, it's kind of amazing to me that sometimes when you just call and ask people, they'll give you information that isn't necessarily published. And I know it's time consuming, et cetera, but that just is a thought that maybe, you know, the university, the health systems, the state universities that you pointed out, some of those really big ones are very clear who they are. And if you can get the person in HR or wherever it's at to just have a chat a bit about it, it might not be a bad idea. That's all.
Yep. And I think that's absolutely something we'd love to do. Might have to wait till after September to have bandwidth for it, candidly. All right, next slide. All right, so this is really just a summary before we open it up for any final discussion. So obviously there are risks with both. If a UHP is primary, ERISA challenges could potentially delay implementation or force kind of a temporary adoption of having it be secondary coverage. And the issue is not so much regulating the ERISA plan, but really forcing that coordination of benefits structure onto ERISA plans. And that's legally a gray area. If the UHP is secondary, we'll have those parallel coverage structures that may persist for a longer period of time because there is, you know, perhaps other reasons employers want to keep those in place. And those administrative simplification gains, again, may phase in over a longer amount of time. And I believe that's it. So would love to just get some direction from this committee. Judy.
Thank you. I have first is a meeting point of order, and then I have a comment about the slide. Isabel, can we make sure that we're capturing the comments in the chat as part of the record? I know we're recording, but committee members are making great comments in the chat. I want to make sure that we capture those. My position on this slide is really, it's hard for me to take off my provider hat sometimes. And so if the UHP is primary, simplicity is the way to go. I'm one of those many providers who kind of go a little crazy when I have to figure out which insurance to bill when someone comes in with an injury. So I err on the side of simplicity.
Thank you very much. Eve.
I think it would be really hard to implement UHP as secondary. Providers won't be credentialed with any of the other insurance companies. Everyone will be out of network in the state of Oregon for whatever the national brand insurance company is. And that when you are out of network, often you can't do things like refer people to a specialist, prescribe medications. There are some real care delivery challenges to that. And so how do we overcome that? Is it just that now we only can make referrals through the UHP as the secondary insurance because that's the only one that we're contracted with? Or how does that function if everybody's out of network? And the only alternative is that we have to continue getting credentialed with every insurance company on the planet. And that sounds really awful also. So, you know, I think if all we were dealing with was billing, probably that could be handled centrally at the UHP, and UHP just pays providers and they bill out. But I think it's much more complex than that to be trying to deal with all of these insurance companies out of network.
Thank you. I'm not quite sure I follow. I'm wondering if you could elaborate, because there would still be these other insurance companies. I'll just, you know, Aetna, United, national ones, that would do their own credentialing. So I guess I'm a little confused when you say everybody would be out of network. Maybe I'm missing something.
So a provider has to credential with
Right.
every one of the insurance companies in order to be in network. When we see patients who are out of network, we have terrible problems coordinating their care because the insurance company wants to send them to someone who's in network. So has been a real complicating factor for us when we get out of network folks.
Okay. Okay. Thank you for clarifying. Tony.
Yeah, I mean, the construct of the navigating ERISA is an idea of a payroll tax, right? And pay or play. And I think I'm actually on the side of the secondary. And as a provider, I feel that, and I'm hearing all the comments. I think this is terrible. But I think that the idea that if a employer in the state is going to pay a significant amount on their payroll, it is incentivizing them to be participatory in the plan. That's obviously incomplete, and I don't have a crystal ball about that. But I would suspect, and I don't know, maybe this would be some of the evaluation process with that, is to do a survey with that. But I do worry about the concerns of ERISA and that coming forward. And I would think that the bulk of employers would just lean into this plan if we execute it as we envision it. It does create some redundancies in the system, and we're not creating the great deal of efficiencies. But I think we do need to pay attention to those ERISA constraints that we find ourselves in statute.
Thank you. Jamie.
If at the risk of just sounding as uninformed as I actually am, I had questions about if it's possible that in-state employers have to have primary, and multi-state employers could be asked to opt in or opt out in either direction that we think is going to work better. And I don't know if that's feasible or if that would sort of navigate some of those ERISA challenges at all, or even if employees are given the option of which direction they go, because that could help employers shift, you know, if employees are able to do that. But I don't know enough about it to understand if that's even possible.
Yeah, you and me both. I think that warrants some further research, though, if maybe ERISA plans could be carved out from the primary coverage piece. Thank you for that. That's research I'll do. Mike.
Well, I want to build on Jamie and Tony's comments. And I want to make reference to something that most of you haven't seen, but I was privileged to read a document, I guess, Mickey, that you're in the process of creating, and it has to do with basically going deeper on issues. And I think this is one of those issues that almost requires a a little bit more in-depth analysis and I would say simulation, because I think we're trying to guess what are the behaviors that most would encourage ERISA employees to in fact go earlier into the UHP, because there's going to be problems either way. So I would not make the case that UHP should be primary and do everything. That might turn to be looking like that's great from a provider perspective and might be the worst thing that would happen to the providers if in fact it delays implementation things. So my caution here is to make sure we really think this one through. This is a major decision. If we go with primary, we will have to make even greater cuts if we're going to have a credible tax structure. So again, all these issues are interrelated. So thank you.
Jamie.
One of the other questions we might want to explore is with the issue of provider simplicity. Is it possible that providers would opt out of accepting non-UHP patients because of the administrative complexity? I mean, we've considered it the other direction, like, you know, in states that said everybody's covered, and then the providers said like, well, I'm not going to accept that payer. But could it be possible that the reverse might happen? Again, question I'm not sure about, but maybe deserves explanation.
Yes, definitely worth exploration. I do believe that you could require everyone to take it, but I will add that to my list. Thank you. Tony.
I think that's a good question, Jamie. I just think that you know, in contrast to one plan, personally, I would see providers. I'd be shocked to see any of them not to do that. One, because of the extensive network. I mean, if this comes to fruition, you'd have the bulk of patients in the state that would be on the plan. So you would be opting out of the opportunity to do that. Now, maybe somebody in direct primary care, that may be a choice of theirs. The other thing I want to elevate in this, I think, is a very strong point, is the consideration of unions, and that being a con in going with a primary with UHP. I think that, Mike, you bring up a very valid point of having those conversations and consideration with that, with buy-in from a political standpoint.
All right, I do want to be cognizant of time, but we'll do these last couple comments and then jump forward. Eve.
So if we do go with secondary, I think we need to play this out, because the worst thing that's going to happen is someone comes in with, pick a plan, United Healthcare as their primary. Primary care writes a prescription, it gets denied by their primary, and then it has to be rebilled through the secondary, and that delays care for the patient because the provider is not credentialed with the insurance company. So I really think that if it's secondary, we have to solve this problem of how do we make sure that we're not dealing with denials on the front end, that we're having to either appeal, or it's clear to the provider that we just bounce it immediately to the UHP as the secondary insurance. My concern is delays in care and the inability for people to access care because of the denials and a lack of clarity on how we move through that process as a non-credentialed provider. If we can come up with a solution to that and make it really clear to providers, I think we can make it secondary, but we cannot have delays in care as a result of this.
Tony.
Sorry. I just would see an uproar from people, if they were in that and they came to that, this might be the case, and we shouldn't be planning, we shouldn't be designing it this way. But I would just offer that I think you would see, a short-term basis of that, and there would be such an uproar from those employees to their employer that I think that they would transition on to a simplified plan.
All right. Co-chairs, I don't know if there's any final sort of hand raising for one or the other, or I'm also happy just to move forward with the discussion we've had. Okay, hearing nothing, I think we'll move forward. Thank you all so much. I think we can,
No vote.
yeah. All right. So this one, oh, go ahead, Judy.
I'll just add. So the intention, I think, when we have this kind of robust discussion with divergent comments, the intention is for staff to capture that in its whole gestalt and then communicate that to the board, which is really the decision-making body. So all of the comments are valuable and important and will inform board decision-making. So I don't want someone to think that wasn't useful just because there's not a vote. I mean, this is really important work.
Thank you for that. And yes, all these comments will come forward with all the complexities that were raised and a little bit of additional research as well. All right, so let's talk a bit about financial transition strategy. And this is the first time we're discussing it. We're not looking for any kind of decision. This is really to lay the groundwork, and there's a bit of homework that we're asking folks to think about. And then I think in 4 weeks, we'll revisit this topic. All right, next slide. So really what we're going to be discussing are 3 questions. And again, these are directional questions. We're not getting into the weeds. We're not talking about specific numbers. All of that analysis, unfortunately, is going to have to wait for a little bit. But at a high level, trying to get a sense of when do we think that UHP financing mechanisms should begin? How should transition financing occur? And whether transition protections should exist. And we'll go into what each of these mean. Next slide. All right, so our scope of discussion, just to be really clear about this, we're talking about when and how UHP financing mechanisms would be implemented to ensure a smooth transition. We are just talking about those mechanisms that have been discussed at the board related to financing. We're not at this point introducing new transitional funding startup mechanisms. Part of what we're trying to get a sense of is how much are we going to need to go out and identify some of that specific startup funding. So timing is what we're talking about, and then how some of those tax and instruments are going to be implemented, including whether or not we want to have protection. So just by way of background, for instance, Vermont had a whole plan to phase in small businesses. Is that something we would want to consider protections for certain employer types, etc.? What we're not talking about startup cost estimates. We just don't have that kind of financial expertise available to us right now. And again, we're just trying to get a sense of how much of that do we need. We're not talking about financing recommendations, operational planning, or steady state costs or administrative savings. None of that is part of our transition plan here. Next slide. So just by way of overview, for those of you that, aren't able to attend every single board meeting, this is the financing plan that the board has been looking at. It consists currently of 5 tax instruments. The last one, a little bit under debate, so you'll find that I did leave that out of your homework because it also is the smallest. But just to note, this is the steady state financing plan. So this is once the UHP has been established, once it's covering everyone. These are the approximate numbers that we're looking at right now. So 2 fundamental instruments, an employer payroll tax and a healthcare personal income tax, and then some smaller amounts to be collected through the corporate income tax and the corporate activity tax. And you don't need to memorize these, but just to give you an idea, these are kind of the main things, and that about 50% from the employers and about 40% from that personal income tax. Next slide. All right, so our first question, again, not looking for answers. I recognize this is the first time we're asking you these things, but when should financing begin? And as we think about this whole process, we've got a lot going on here. So first, we've got the planning phase, which we are in now, and we all know that planning can take quite a bit of time. At some point, when this starts to become more of a reality, we will begin developing the infrastructure needed in order to support a UHP. And that could proceed right up to launch, which is that kind of vertical line that you see, or it could even proceed a little beyond depending on how that works. There are a number of decisions that haven't necessarily been made, which is why we're keeping this pretty high level. We know that a couple years out from launch, we'll probably want to start building reserves for a UHP so that we have that ready to go. And then, of course, at launch, we begin the process of coverage expansion. And there's this phase that I call transition buffer, which is just acknowledging we are going to have a period of time where there's going to be some double paying costs, where there's going to be some extra administration happening because transitions are messy and they cost money before they start saving you money. So as far as when should financing begin, and again, we're talking about when should those taxes possibly begin in the planning stage, maybe at infrastructure development, maybe at the point that we're building reserves, or maybe they just begin at launch. And so the real question that we're asking, of course, is should any of that steady state financing begin prior to launch in order to help support our transition needs? Which of course reduces our reliance on having to obtain other funding sources. Next slide, please. So pros and cons, this is pretty straightforward. Just noting that the further in advance that we do start financing this way, we can have earlier reserve accumulation. But we also do have some downsides, which is there is obviously more pressure to really produce tangible benefits. There is that double payment concern for however much period of time. Whereas financing closer to launch, you get that reduced perception of paying before there are any benefits. Your taxes are aligned with something that's very visible, but you do have greater implementation pressure right at launch. You don't necessarily have that cushion built in, and your implementation phase is contingent on finding and maintaining funds that exist outside of UHP control as well. So there's pros and cons. I truly don't have a preference, so you won't offend me with anything. I'm actually just wildly curious what members of this committee will think. Next slide. Next slide, please.
It's not happening.
Check in with Isabel and see if she's
Yeah.
frozen. She had a little bit of I can switch over in just a sec.
Okay.
Oh, there we go. Okay. So give me 1 second. I am not nearly as smooth as Isabel is when it comes to this, so apologies. Let me see here.
I can also share. I have the deck open.
Okay, hold on 1 sec. Yep, okay. I think I'm ready here.
All right, I got it.
Oh, you got it. Okay.
Okay. All right, so as we're talking about this, transition period, in concrete terms, we don't actually know how long it's going to be, but we can estimate that this could be anywhere from 5 to 10 years, including time that is both before and after launch. So this is just one potential time frame here. I've been thinking about how if there's legislation in 2028, how if this launches in 2032, for instance, we've got about 4 years there where we're doing that governance and planning. We're building out IT, we're testing, we're bringing providers on, we're building reserves. Then there's the launch phase. And then there's, at least a year where we're in stabilization, where employers, as their own plans are ending, are rolling into the UHP, where we're doing all of that. And this is our transition phase. This is the phase where things are going to be, not quite as cost effective as they will eventually become, because we are in a transition. So question 2, and this is very closely related to question 1, which is the when, but this is how should that transition funding occur? And these are just 4 options that I came up with. I'm sure there's any number of hybrid options. One I call the full start, which is all revenue sources begin simultaneously at that full rate. 2 would be a staggered start where different revenue sources can begin at different times. There could be a rate ramp where revenue sources begin below that full rate and increase over time. And then 4th, there could be a hybrid. There could be any combination of staggered starts with rate ramps for maybe some, but not all, or maybe for all of them. And again, there are pros and cons to both. We know that cliffs can be kind of shocking for folks. It's going to be really something if one year you don't have this on your tax bill at all, and the next year you do, but also ramps create complexity. So it's really a matter of, what are the different trade-offs? What do we think the value is maybe in one approach versus the other? And again, this could differ based on the different tax instruments as well. So a simple question that we're asking all of you. An example timeline, this is very, very busy, but I will try to walk through it slowly here. What I've attempted to do is kind of illustrate really what we're asking and how this impacts our potential startup fund needs. So those areas that are red, that indicates a funding need. So we need funding, even now we're getting funding, we're getting that funding currently through the general fund. And hopefully we'll continue to get some money through the general fund. But as we go and as, for instance, infrastructure is being developed, those costs are going to increase. And so it starts to become a question of, do we think we can still continue to get that from the general fund? Or is this something that we want to start pulling in our own eventual UHP funding sources for? So for instance, in this first one, if we did a kind of full start where those tax rates kick in all at once, simultaneously, but not until that launch point, then we're looking at a funding gap of, this entire pre-planning time, we're going to need to, figure out where that comes from, and that'll be down the line. If we did something like staggered that kicked in mid-implementation, we'd be looking at perhaps something like this. And again, these are just examples of what it could look like in terms of there is less space now that effectively needs to get filled. A rate ramp would be different, of course. So just a couple different options that I really wanted to show visually, and hopefully this wasn't too confusing. All right, and then question 3, transition financing stabilization. So as we move through this transition period, should transition protections exist? And potentially for whom? Providers, small businesses, other employers, rural systems, lower income households. Those are just some of the categories that occurred to me. Now there's 3 main cohorts that I thought were worth some consideration. Of course, providers being one of them.
Lee, your slide hasn't advanced.
Okay. Oh.
We're still on number 1.
Screen sharing, why is screen sharing paused? Okay. Let me try to stop share and then reshare it. Okay, can you all see this now?
Not yet.
In just a sec, it's coming up.
Still nothing.
Yeah.
No?
Let me try mine, Lee. I'll give it a whirl.
Okay, I will stop that share.
See, we go to pieces when Isabel isn't helping us.
But while we're waiting for the slides, I will just continue sort of talking through this, which is to note there's kind of 3 cohorts that I would suggest people think about whether they would want to extend any kind of transition stabilization to. The first being providers. We know that our statewide hospitals are operating on, as one of our co-chairs noted, razor thin margins in 2024. You can go forward to the one that's got the 3 boxes. Yep, perfect. In 2024, those margins were 0.3% on average, which is just, effectively nothing. Under those margins, we found that more than 70% of Oregon hospitals were showing signs of financial stress, which is not good, because when you need a hospital, you need a hospital. And we want to have healthy hospitals. For all the other, ways that we could talk about hospital pricing, they are an essential resource in our healthcare system. Also, just noting that we have 25 critical access hospitals and 37 rural hospitals. These are essential for care in many parts of the state. And so it is imperative that we keep these hospitals open. Regarding employers, we know that a large number, approximately 96% of Oregon firms, have fewer than 50 employees. So that is a very large number of small employees. Judy, go ahead.
I'm sorry to interrupt you, and I guess I want to just state the obvious. Those critical access hospitals and rural hospitals, they're the ones precisely who are going to have to figure out alternative sources of revenue to stay afloat after a transition, potentially, because those funds for critical access rural health clinics are tied to federal sources many times.
Yes, a great point. Mary Lou.
I have a question because I don't know the answer to this, but I do know that out in Eastern Oregon, where I reside part of the time, most of the small hospitals out there have been actually purchased by larger systems, either out of Idaho, St. Alphonse, and whatever the other one is over there, or some of the others. So I'm not sure exactly how many of these smaller rural hospitals really are on their own versus being under somebody else's purview. Providence has purchased quite a few small ones around the state. So anyway, I really don't know the answer to it, but I do know that they're not all just on their own.
Yeah. That's a great point. Thank you. All right, so again, then employers being another one. We know that we have a lot of small employers. Again, they don't necessarily account for a large number of employees in the state, but a lot of businesses are smaller than 50. 60% have 5 or fewer employees. That's really, really quite small. And that they do account for about 54% of Oregon employment overall. Now, it can vary quite a bit, but small businesses tend to operate with much more limited cash reserves on much thinner margins than large businesses. And then looking at households, and I think somebody made this comment as well in the previous presentation, Tony, it might have been you, but just noting that a lot of people receive coverage through their employer, and a lot of those folks, approximately 1 in 6 Oregon employees, are represented by unions that have negotiated health benefits. And unions are a very real force. They've been involved in, negotiating healthcare benefits for a long time. It's been a big part of what they do. And that is something that needs to be treated carefully, I think, as we go through this transition. All right, next slide. These are just some example mechanisms that could be in there. So, phase in for small employers, some sort of hold harmless provision for certain folks, having risk corridors, temporary dual participation rules that would be, maybe for employers while they are perhaps waiting for their contracts to end, because some of them could be in multi-year contracts with insurance companies, all kinds of things. So there's a ton of options here. Next slide. And this was just another way, as I was going through it, of thinking through these questions, kind of the timing. When does each revenue source begin? Does it start at a full rate or phase in? And then is there kind of a particular trigger, which is really related to that timing? Is it tied to a certain date, a certain milestone, to a certain amount that is needed, or is it going to happen at launch? And I believe just one more slide. Oh, go ahead, Mike.
Why don't you finish your last slide? But I will want to go back to those questions.
Great. And then my last slide, this is some homework for all of you. As I said, I think we're tackling this again in about 4 weeks. And I just wanted to present the questions along with 4 of the 5 tax instruments. You'll note I did leave off lodging tax because the board seems a little iffy on that one. But as far as these other 4 taxes, to do a little thinking about what kind of timing, Is there a certain trigger? Should there be a ramp? And should there be some sort of stabilization for each of those? So, you know, for instance, that provider payroll tax, I put very vague terms here, but thinking like early implementation, mid implementation, or at launch. You know, and this can just be for your own sake to get some idea. Again, those dollar amounts are included up at the front. And we're not trying to be necessarily really precise here, but just to get an idea of, you know, what approaches do we want to take? Are there certain populations that this committee, you know, wants to call out as ones that should be protected during the transition period? And that's it. We can jump back and Mike.
Great, thank you. Yeah, I want to just set some financial construct for this. So imagine, if you will, we're in a world right now where we're in what I'd call the 7-digit world. You know, we're in budgets in the between 2 million and 5 million, etc. And we're about to go into a world of 10-digit numbers, if you will. So we're going to have to start thinking about what are the ramifications of things in the billions, not just in the small pieces. So getting to your point, as I've tried to think about this, I know we have to solve what we, I guess, currently calling tax rates that we should probably call income adjusted premiums or something else that doesn't have the word tax. But we've also have to fund a certain amount of transition in terms of monies, and we have to also solve for reserves. So each time we build, have more reluctance and more exceptions, etc., we move the plan from the possible doable to you know, we're beginning to put, you know, lipstick on a pig. So what I'd suggest is begin to think about this in terms of if we're going to do X, that there needs to be some mechanism to raise some amount of money prior to this. So I don't think the question is when, some amount, and then within that, what things would be the most viable pieces. So just to suggest, so that any of you can change this, reject this, but at least it'll get you thinking. The EPT, if it was a certain small piece of that started earlier, it would begin to fund some combination of the funding, because you've got to develop this organization prior to start, right? So I would suggest looking at that. So I'll just make up numbers but these are big numbers, right? If you had a 1% in the employer tax. Now, remember, I'm going to use not numbers from 2022 to prior to 2032. It'll be in the scale of, instead of 800 or 900 million, it'll be more like about 1.4 billion or so for every percent. So an increase of an EPT of 1%, if done prior to 2032, and again, any of you can invent, would you start that the year before, 6 months before, 2 years before? But there needs to be some accumulation of capital and operational funding. And then the second point is, I would argue, to the extent to which we don't do that, we have to be much more aggressive in terms of either reducing benefits or achieving savings in some meaningful way. And that's how I've looked at the numbers, and I'd appreciate anybody else both reacting to that, but also coming up with their own reactions. But I'm trying to give a sense that in terms of the timing question, that maybe one of the revenue sources, and I would probably start with the biggest one, EPT, should begin a little bit earlier. And obviously, I wouldn't started at full rate, but I would phase it in. And obviously I would look at milestones and arguments and things of that sort. So that's just to get the discussion going.
Thanks, Mike. Mickey.
Yeah, yes. So to piggyback off of Mike's, I am also kind of trying to figure out. So for example, if we have startup capitalization and we're looking at seed funding, startup cash, working capital, staffing costs, technologies and systems, legal compliance setup, office and infrastructure, reserves and contingency funding, marketing communications, customer acquisition, early operating losses and all that. And I'm like, well, how much are those? Where do I get that information? Because I'm really just new and starting to catch up. And then I'm looking at, operating liquidity before tax revenues stabilize, the reserves, and then maybe cash flow bridge, like where do we get that and how do we calculate what those should be? I wonder if at any point did the finance committee make recommendations on numbers for those?
No, and unfortunately, we do not have that. The startup cost is going to be part of our sort of phase 2 analytics. What I would suggest is in filling this out, I think that kind of thing is really appropriate to put as like a trigger, like, this much of the tax should phase in to cover, the staffing, to cover this part, etc. We don't have the consultant resources at this time to estimate those, and that is part of our, continued funding request that we have.
Okay, so, Okay, so just like put placeholders for now, just kind of
Yes,
like, okay,
that's
got
what-
it.
Yeah,
Okay, cool.
unfortunately, that's where we're at.
Thank
Eve.
you.
Yeah.
So I do think a much smaller scale program, but something that may be worth researching more is Paid Leave Oregon and the implementation of that. So there was the taxes went into place some months ahead of time. I don't remember how many months, but it was a set of months where you had full taxation and they were building reserves, and then we went live. I think many more people have utilized Paid Leave Oregon than maybe was anticipated. I would love to just use that as a case study for starting something like this statewide. It won't be perfect in how it's, one-to-one comparison, but how did it work? What were their lessons learned that we might be able to learn from? I think the other thing that I worry about going straight to just employer tax to start. I think there will be a ton of opposition. We already have a state that is pretty unfriendly to business from business perspective. So I think I would be worried about that. I think it's got to be shared across individuals and businesses, but is there something that we could provide? Some kind of a benefit. Maybe the benefit is we will protect you from bankruptcy. In the state of Oregon, at the point that you start paying some amount of taxes, I do like the idea of a ramp up if we can do it. Maybe go to full force soon before people can see it coming. But, do we say you're starting to pay taxes, you have bankruptcy protection, or you have protection from losses above X amount for medical costs for a year that's out of pocket, where folks could see something that they were getting for what they were paying, and hopefully it would cost less than what they were paying, which would be the total goal, right? Because we want to build money in the system. But I just think we're going to have a really hard time getting folks on board with paying taxes for any kind of an extended period of time for something that they receive no benefit for. So kind of thinking through how to strategize there.
Thank you. And we can absolutely reach out, see what we can learn about Paid Leave Oregon. Mary Lou.
Yeah, this is a very complicated question and issue, multiple questions, and I'm wrapping my head around it and have been thinking about it before this presentation, actually. And it kind of depends too on what we're envisioning the model to be of this public corporation. And, everywhere from kind of Milliman's projection of, 20,000 employees at some point to, 1,000 people that are really more doing policy and doing oversight and partnering with some of the other major providers, for example, in terms of like, the payment of claims or the things that people have expertise in. I mean, it's just kind of, I don't know that I've got a clear picture of what the board has decided. I don't think we have exactly on, kind of what the organization, what the public corporation will, the actual functions it will be doing and what the estimates are of those costs. And yeah, we're going to need some money up front. But I did ask Charlie Swanson back a ways, if you raised like a 1% or a tax, and I can't remember now whether I asked him if it was employer or personal, and maybe it was both, but it was like $1 billion gets raised in a year. So that's a lot of money. And on some stands, it's a lot, and some it's not very much, depending on what you're going to spend it on. So I'm just having a hard time really coming up with what I feel is anywhere reasonable guess at these things. And I'll just leave it there.
All right, thank you.
That's polite to say thank you.
These are hard questions, so I
Yeah, I'm not
sympathize.
sure that you really are thankful, but anyway, thank you for saying that. That's very nicely.
That's why you all have 4 weeks to do your homework. Jamie.
The other thing that seems obvious, and you can say thank you, Captain Obvious, in the chat if you'd like to, is that because we didn't really have closure on the sequencing discussion, it seems obvious that if there is a big bang, we need more money before it starts to get everything the heck ready at once. Whereas if there's more of a phased approach, that means a little bit lower cost initially, and so there might be less required in advance. The other question that I have about it, and again, I'm just trying to think outside the box a little bit, is in primary care transformation, it always costs the primary care organization more to get ready to transform. And once the transformation happens, then a couple years, usually a couple years later, the savings begin to occur. If that model is sort of similar, do we have to look for the same funding mechanisms to create infrastructure before it goes live? Or can we look to alternative funding structures for preparation? And I don't have any great ideas about this, but could there be, as I think Mike was talking about, not so much a phased approach, but a planning test or a pieces part that gets initiated that can generate some savings or some revenue? For example, could we have a statewide formulary initiated that could generate some savings, or a Medicare Advantage plan that could create, so there might be some other funding mechanisms that aren't exactly like the payroll tax, or maybe it's a sugar tax. Maybe we do a 1% sugar tax and we say this is just a health tax because it sucks to eat too much sugar. It's bad for everybody's health. So we just put a sugar tax on and we bank that and use it for infrastructure building for health delivery. Similarly to how like tobacco taxes created the money to fund stop smoking initiatives in the state. So I'm just wanting to open up that thought process a little bit and maybe think outside the box for some of those initiation costs. Maybe we think of it as a separate thing, and like we don't call it a tax for healthcare, but frame it at different.
Mimi.
Yeah, I'll just state, and I should have done this prior to this meeting, so apologies, but our Echo Northwest, our great consultants, did create a memo talking about funding mechanisms for reserves, which is not the same as startup costs, but is similar. And exactly as you were speaking about, Jamie, there are some definitely different types of mechanisms that are implemented to do that. So I will share that with you all. So just to know others were thinking along those lines, and apologize. Had I been thinking properly, I would have gotten this out in advance.
All right, Tony.
Yeah, thanks for bringing that, Mimi. I think that was a really good review and taking a look at that. And I think if we're sequencing, obviously, I think plays into this and is intricately interwoven with that. So I think it's a challenging task here to separate those two. I expressed my concerns about some of the sequencing and leaning more towards the Big Bang. So I really appreciate the conversation, Jamie, in thinking of, we have a revenue stream that is done a great job by Finance and Revenue to create what would be the status quo to doing ongoing maintenance of that. But it hasn't been defined as far as to build up the projections, probably 2 to 3 months of the funding that would be for startup costs that Eco Northwest recommended with that. And with regard to the impact on vulnerable communities and our vulnerable health systems and all of that, we're challenged by the understanding that the status quo is harming all of those areas right now. Our hospital systems is suffering because of the payer mix of Medicaid and challenges with HR1, and primary care is struggle on that. So I guess, my point here is to be careful about the worries of the impact on this exacerbating that system, which we need to be careful. I think we need to pay attention to from an ethical lens of who's the most vulnerable and put in that, but with the counterbalance of don't limit that too much for us to put in place this effort to get it across the finish line, because we know inevitably that would support our communities better, support our hospital systems, our primary care network, and all the things and the benefits with that. So I'm interested in the slower ramp up. I'm very cautious about the phased in sequence of different sectors and whatnot, because we still have all those administrative efficiencies. But the reality is, I think we just need to set a plan A, B, C, and thinking about the governance board considering those because of the unknowns of waivers and inclusion of different sectors that we need for that financing. I think I muddied the waters more than anything in my comments there.
I think that was great. And seeing the time and no hands up, I think it's probably a good place to wrap it, just because I know that, we're going to come back to this topic. And I think exactly what you said, Tony, is what we're looking for, something like an option A, B, C, and these would be high level, such as we think, an employer tax should come in first, and then this tax, and we think that they should ramp up, or we think everything should start all at once. And as noted by a couple committee members, yes, the implementation sequencing will heavily influence this. Unfortunately, we did not end up having time for the board to discuss that in their last meeting, but I am very hopeful that by the next time this topic comes up, the board will have seen that topic and we will have something to go off of. Mike.
Just one final note, and again, I alluded to this before. I wanted to acknowledge and thank Mickey for at least writing a document that maybe we can all share, I think the thinking that goes beyond on Mickey's document will be very helpful, because we need some construct to deal with the fact we've got about 8 or 10 very important variables, and I don't know how to intelligently do that other than what you just suggested. Maybe do 3 or 4 scenarios and look at the implications of that, and that's exactly what I got out of reading Mickey's note that hopefully you'll all get shortly.
Oh, thank you so much, Mike. I appreciate that, because I was telling Mimi, I thought that if I shared that with folks that I would get fired, and I'm a volunteer. But I'm so grateful that you found it helpful. And I was also sharing with Mimi that I'm gonna courageously also try to take a stab at putting together a business model canvas that we could play around with, if you'd like, where we could also show what's already been discussed and what might still be missing. So I'm going to attempt doing that by this weekend as well and share it, if that is something that you'd like to see. Thank you.
Yeah, I'd be interested in seeing what it is that you've done.
Thank you.
All right. And I am going to suggest, we thought that this might happen, that we'll table our engagement discussion because of what we're talking about now. What day is today? So apologies, because some of this is no longer up to date. We're talking about what might be coming up next time. I can tell you that our next week, Lee's going to present something on prescription drug cost saving strategies, which I think will be great. We will then get to our engagement. We're not going to talk about workforce at that time, so you'll just have to strike that from this. So apologies, this is maybe not the most up to date. We'll send something out that has in an email along with the Echo Northwest memo that has more our upcoming topics. And I will say, everyone's like, what did Mickey write? And the answer is she wrote an incredibly thoughtful and well-written memo regarding kind of how we're thinking about all of this transition work and some other things to do, which we will talk about at our next meeting and will also get sent out. So apologies for that. And now I'm going to stop sharing my screen just for a moment because I need to check in with Isabel, which I hope I can connect.
I'll see if it cooperates for our last couple of minutes, hopefully.
Okay. Oh, good. I'm glad you will be running the show then.
Yes, so as always, we really appreciate members of the public sharing public comment with the group. Today we have 2 people signed up for public comment, and you will have about 2 minutes for your comments. And once in just a moment, I should, fingers crossed, looks like it's working, get the timer up. And with that, and for deadlines for public comment submissions, written public comments can be sent in 72 hours in advance of the meeting. And for oral public comment, please sign up 24 hours in advance of the meeting, and that can be done via our website. So the first person we have speaking today is Lou Sinninger. You should be able to unmute and share your comment now. Lou, are you ready to share your comment? There you go.
Yeah, I mean, there it goes. I just wanted to get the visual on there too. Thanks. Very interesting discussion. It really is challenging to switch from the system that we have to a universal system. The financial, how do you build reserves? I wonder if anybody could look into a government bond of some sort, state bond. Maybe that would give you the reserves necessary to kick this off. I was really prepared to give I thought you were going to vote today, but Isabel told me no, we don't take comments before the vote. So for the primary and secondary question, number one, the task force kind of figured this out. They said, well, you know, if you want to keep your insurance, you can, but we're applying a payroll tax, so that's it, right? And then I got to thinking about what primary versus secondary payment suggests that there is a benefit not covered. And I would kind of look around and see if there was any benefit offered by any employer insurance plan that would not be covered by universal health plan. And basically, whatever conclusion you come to in the primary, I would suggest that we keep the primary, because if we're not primary, we will not change the administrative costs. That will mean that the insurance companies have, we won't have control of the market, and insurance companies will still control the market. And as long as they control the market, they control the costs. And that's not a good way to go. Last thing is the timing of this plan is going to, and including ERISA, Ro Khanna has a standing waiver plan in front of Congress. If this changes, if the administration changes, then that waiver plan could go through, which would conclude and get rid of ERISA being a thorn in our side. So thank you for the extra time. I had a lot more to say, but thank you.
Thank you, Lou. And next up, we have Colin Stackhouse.
All right.
You should be able to unmute and share your comment now.
Hello, can you guys hear me okay?
Yes.
Okay, great. Hi, thanks for the opportunity, all of you, to give comments about this transition. My name is Colin Stackhouse. I work with Healthcare for All Oregon, and I am serving for a few more months on the Community Engagement Committee alongside you guys. So fun to have a committee person, or I don't know, I'm having fun. Glad to listen and see what you guys are up to. I have a comment, which is a big concern personally, based on my previous job, which was admitting at a major Portland hospital, doing the registration, admission. To be candid, it's what sort of galvanized me to want to work towards a universal healthcare transition, because the process of connecting patients to 400 different kinds of Blue Cross Blue Shield insurance is super unnecessary. Also, sort of the harms that I participated in by telling these Medicare patients that they likely would have high fees felt, a little moral injury, nothing compared to what a physician experiences, but telling these patients sort of in their worst moments that they might have a big bill was really hard. So all that's to say, I did love that job, and there's so many people that are in admitting and registration that love the work they do and love the aspects of patient care. And these individuals are going to be, hopefully, fingers crossed, in 2032, when this is implemented, they're going to be on the front line of registering these new patients. And with every new patient that they connect to the system, I know there's going to be some automatic enrollment and an ease of enrollment as much as we can do. And still, I think likely that human to human interaction enrolling is a likely scenario at these clinics and hospitals around the state. And with every new enrollment that a registration person facilitates, they're like one step closer to putting themselves out of a job, because the convoluted system is what has hired them in the first place. So I encourage you folks to try to consider creative ways to assist those administrative and registration people to their next steps. Thank you.
Thank you, Colin. And that concludes the public comment signups we had today.
Thanks so much, Isabel, and thank you everyone for your engagement and time this afternoon. Just as a reminder, the homework about the financial transition, answering the 3 questions, feel free to look back at the slide deck that Lee provided to help guide your thinking about that. Bring any questions to our next transition committee, but that homework isn't due until the 25th. so you have some time. Anything else for the good of the order today?
So the slide deck will be on the website, correct?
It is.
Okay, I didn't see it before. All right, I looked. Okay. Maybe looked too soon.
Thank you everyone for, oh, Jamie.
I was just wondering if we could receive an email with the questions.
Absolutely.
Help me
Yep.
to.
I
not
can do
forget.
that.
Thank you so
We'll
much.
just give it a little package, a little gift from the transition committee to everyone.
Thank you, Director McDonald. And just as a reminder, folks, if you have questions, just send Mimi a direct email. Do not reply all to the group. I know that she'll be sending out information. It's for educational purposes only, but certainly if you have questions, ask them, and Mimi or staff will get to them. Other questions, requests, or comments? Thank you, everyone, for your time and commitment to this good, hard work.
Thanks, Lee.
Bye-bye.
Thanks, everyone.